I think we will get started, everyone. Thank you all for joining. My name's Douglas Akadny. I'm the director of the Neuroscience Mental Health Institute. Welcome to our evening of nerves, neuropathies, and resilience, story of inspiration. We're really delighted that you can join us. I'm going to start sharing my screen here a little. Right, and I want to see here. Right, I want to start out by acknowledging that we're located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. This is a presentation of the Neuroscience and Mental Health Institute, and we're going to start off the evening with just a little bit of an introduction to NMHI for context. And Ramona's going to just put out a little video on about us that can also be found on our website.
The brain and spinal cord are the most complex and important parts of the human body. They control everything we do and drive us to feel, think, move, and learn. Hundreds of billions of interconnected cells in our brain and nerves, all acting in concert, allow us to experience the world and make us who we are. But there is still so much left to understand about this complicated and fragile organ. 1 in 3 Canadians are impacted by a neurological or mental health condition at some point in their lives. From Alzheimer's to multiple sclerosis to depression, these diseases and disorders are leaving a devastating impact on the lives of millions. Fortunately, there is hope in knowledge. By furthering what we know, we can find a way to diagnose earlier, treat more effectively, and implement preventative measures, easing the burden for those afflicted and improving their quality of life. Through the efforts of dedicated scientists and clinicians, we can work towards better brain health for tomorrow. At the Neuroscience and Mental Health Institute, we are dedicated to improving brain health through research. Located at the University of Alberta, we are home to over 150 world-class scientists and clinicians, all dedicated to the same goal: to better understand the brain and nervous system in order to develop transformative improvements for those affected by neurological and mental health-related diseases and disorders. By working collaboratively and taking a multidisciplinary approach, we are able to reach new insights and innovations faster. Through transparency and knowledge sharing, we are working together to make a difference.
Right, thanks for listening to our little video about the NMHI. Just to emphasize that the NMHI was conceived by the university by scientists, physicians, and citizens, and it's dedicated towards exploring the complexities and beauty of the nervous system, as well as its treatment. And that's the purpose of the NMHI, is to attenuate and eliminate the suffering and disability posed by disorders of the brain, mind, spinal cord, and nerves, the latter which we're emphasizing tonight. Based on transparency, internal dialogue, and worldwide collaboration. Just to let you know that NMHI has a number of components here at the University of Alberta, and I'll just point out some of them, such as the Sensory Motor Rehab Group, the MR Research Center, the Neurochemical Research Center, a group focusing on dementias and Alzheimer's disease, a very active MS research group, something called the SMART Network that develops new technologies for patients, and this important center for prions and protein folding diseases. It sounds like a mouthful, but it's a very, very important institute of U of A dedicated towards finding solutions for things like BSC and mad cow disease and things called Creutzfeldt-Jakob disease. So a number of people come together as part of NMHI, but tonight we're going to talk about peripheral nerves, and I'm really glad you could join us. We have an all-star cast. We have a couple of heroes that you're going to hear about that have dealt with really devastating problematic disorders of peripheral nerves. We're going to talk a little bit about the research, and then hopefully we're going to have a little bit of time at the end for a panel discussion. So we're going to ask you to hold your questions until the end. There is a Q&A box that you can put your questions into, and we're going to try and address them at the end during that session. In addition to thanking the great speakers we have tonight, I also want a special thanks to a couple of organizations that have connected to many of you that have joined, including the Calgary Neuropathy Association, headed by Linda Petois, and Donna Hartland from the GBS CIDP Foundation. All right, so here's what nerves look like. These are these essential connections between the brain, body, and spinal cord. Without them, there's no movement or sensation. We move in a little bit higher, you can see they look like these little blobs with black around them that are the myelin sheath that can be changed by conditions like Guillain-Barré syndrome. But there's also smaller looking fibers here that we can see in between, and they subserve pain, causing neuropathic pain when they're dysfunctional. We go a little bit higher and we can see the ultrastructure of the nerves with the myelin around it, and then these smaller axons. So it's a beautifully organized tissue. It's very different than brain and spinal cord, and has its own unique problems. Here's what myelin looks like up close. These are layers of lipid that provide insulation for nerves to fire properly. And in a schematic, we see that there's a variety of different kinds of nerves, and depending on how they're targeted, will determine what kind of neuropathy exists. So these are sensory nerves with myelin on them, motor nerves that control movement with myelin, and then without myelin, we have pain fibers, and then this huge area that's called the autonomic nervous system, which we may be able to get into a little later. If we focus down on the skin itself, this is a cross-section of a skin and a schematic on the left-hand side. We see these very fine nerve terminals that penetrate through the skin and allow you to have sensation, to feel an injury, to withdraw your hand from an area of heat. And we're starting to be able to understand these very fine nerve terminals in the skin. What kind of injuries can occur? We'll be talking a little bit about them. There's some fancy names for these, but to suffice to say that you can disrupt a nerve by just getting rid of the myelin, even though the wiring or axon stays there. A more severe injury might injure the wiring or axons and require growth and regeneration. Or you can have these transections of the nerve, which are the most severe types of injury. And this is not even talking about neuropathies, which are very common. Diabetic polyneuropathy, 10 times more common than ALS, MS, and Parkinson's disease combined, causing numbness and loss of sensation. So all sorts of nerve injuries that brings us together tonight to talk about this, from radiation from a person who had breast cancer and a wasted weak hand, someone who had a bullet wound through their sciatic nerve, and someone who was in the ICU, and we're going to hear a little bit more about this. So at this stage, I'm going to turn this over to our first speaker, Dr. Robert Augustinus, who is a physician and a patient who is going to tell you his story about a severe neurological problem, a form of Guillain-Barré syndrome, an autoimmune condition, with an amazing story, who spent 6 months and 5 days in the hospital and learned to walk again and to recover. And we're going to talk a little bit about his unusual condition that we're learning a little more about. So I'll turn it over now to Robert to talk to you a little bit.
Can everyone see that? Great. Well, good evening. My name is Rob Augustinus. I'm a physician, a community Imagineer, and now a patient. This is a super condensed version of my life as a patient. This is my story and my journey. But before I start, I want to say some thank yous. Thank you to the Neuroscience and Mental Health Institute for the opportunity to tell my story. Thank you to my wife, Dr. Isabel Chu, and my daughter, Alyssa Augustinus, for advocating for me. I want to thank Dr. Cecile Fan and the medical team, doctors, nurses, physiotherapists, occupational therapists, recreational therapists, psychology, and others. And I want to thank Dr. Sanchez and the medical team and their therapy team at the Glen Rose Hospital. And finally, I thank you to my neighbors, friends, and colleagues who supported me throughout this illness. The community came out and took care of my yard, picked up the vehicle in Cranbrook, shoveled some snow, picked up healthcare aids from the Red Cross, put my garden bed together and to sleep, and all that food. And they did a lot for us. It really took a village. This is me in July 2021. I was 59 then. I was reasonably healthy, working out. But it all started on September the 14th, 2021. I was in BC helping my 85-year-old mother who lived on an acreage 10 kilometers outside the city of Cranbrook. I was also working out at a local gym to stay healthy. It was leg day for me and I did various leg exercises. I was doing this thing called the linear leg press and pushed over 600 pounds. Now I've done that before, and so it was my day. Anyways, I came home that day. I lived in the basement suite of my mom's place. Towards the early evening, I started to develop some leg weakness. I initially thought that I may have overdone it in the gym because it was called leg day. However, when I tried to climb the stairs, I had difficulty. A bit frightened despite my leg weakness, I drove to the East Kootenay Regional Hospital in Cranbrook, BC. I saw the ER doc there, asked him if this could be Guillain-Barré syndrome, GBS. It's hard to tell, he said. I mentioned that I had worked out at the local gym. Did I have a spinal cord injury? They examined me and did all the necessary blood work and tests. And basically everything was normal except for my CK level, which was 500. That showed how much muscle damage that I had done. But that was because of leg exercises. Later that evening, early morning, he sent me home with a couple of Advils. I slept like a baby until 3 p.m. that day. I woke up refreshed, no weakness, no pain, nothing. But 2 hours later, I started to develop the same leg weakness. This time it was more pronounced. I really could not climb the stairs. I could shuffle my feet along this floor. I packed up some of my luggage and went to lay on my bed, and I called 911. They arrived. My mom answered the door. It was kind of funny because they thought the ambulance was there for her, but because they had been out there a few times. Anyways, they took me to the ER and I was seen by the same ER doc. He examined me and did my reflexes. My knee reflexes were absent. I still had movement and sensation in my lower limbs. Upper body was fine and I was breathing fine. He called the neurology team in Kelowna and was told to get some spinal fluids and to give me a high dose of this medication called IVIG, which I was surprised like Cranbrook had in stock, but they did. So the preliminary diagnosis here was GBS. I was later admitted to the ward in Cranbrook, BC. Anyways, I slept reasonably well that evening. When I woke up on September the 16th, 2021, I tried to sit over the edge of the bed to get up. I could not move my legs. They were non-responsive, heavy as lead, and I could not stand. I was frightened and called the nurse. I also needed to use the washroom, but I couldn't. I couldn't transfer to the toilet. So I was lifted and transferred to a commode, as you can see in the photo. I also had some numbness and tingling in my feet. Later that day, I was seen by the medical staff and they also seen by physio. I was lifted to a wheelchair and tried some exercise devices in the gym there. I tried this one device that made me able to sit to stand. Later that day, with consultation from Kelowna and the neurological team there, they wanted to try some plasmapheresis. They didn't have the setup for plasmapheresis in Cranbrook, and I was to be transferred to Kelowna. So I asked why Kelowna and not Edmonton? Well, there is a political reason for this, but I won't get into it. So I obliged. At the same time, my lungs were starting to get a bit weak. I was still in Cranbrook. They transferred me to the state-of-the-art ICU and they put me on a BiPAP machine. I had some slight sedation and then I was flown to Kelowna. Now, in Kelowna, I was received by the intensivist there, I was also greeted by a good friend, Dr. Edith Blondell-Hill, who's a microbiologist and ID specialist out there, and a good friend of ours. I explained to the ICU doctor that I should be transferred to Edmonton. I don't want to stay in Kelowna. I spoke to my wife and realized there was no beds in Edmonton due to COVID. In fact, COVID was so rampant here, they're actually sending patients outside of the province. I also told her to call a good friend of mine, Dr. Koutsigiannis, who's an intensivist, to see if they could find a bed for me, and they did, in General Systems ICU. Now, Alberta Health and BC Health wouldn't pay for the flight, but luckily we had extended travel medical insurance with the RBC visa. Anyways, I was getting still quite weak, my lungs. They put in a tracheotomy and that afternoon and intubated me and put me in a small induced coma, heavy sedation. And I stayed one night in the Kelowna ICU. And then they transferred me to the General Systems ICU at University Hospital in Edmonton. So I woke up a few days later. Interesting, I remembered through my sedation that I was seeing railroad tracks, but they were actually the curtain tracks of the in the ICU. I felt like I was in a car assembly plant. When they let the sedation a lot, I could hear my wife saying, "Hi, sweetie, it's Isabel." When I did finally wake up, I wanted to scratch my nose, and I soon realized I could not. I had no motor function in any of my limbs. I had reduced sensation. I could just move my head, slightly shrug of my shoulders, and I couldn't talk. I was a quadriplegic. I was frightened. I had this thing called locked-in syndrome. I had a breathing tube coming out of my trachea, a feeding tube through my nose to my stomach, multiple IVs, electrodes to monitor my heart, and a urinary catheter. I wanted to communicate, but I couldn't because I was intubated and on a respirator. I tried to mouth my words, but some nurses could not read my lips, and some could read my lips and some had no clue. Those first few weeks, I was frightened, depressed, and I wanted to die. I had expressed this with the nursing staff through a communication. I wanted AS, assisted suicide. I guess I was delirious. But over a couple of weeks, I relented and I was fine. I started to improve. I had the troops sent in, the psychologist, my wife, the nursing staff, and a friend saying, "Look at Rob, you don't have a proper diagnosis yet. You're gonna live." Anyways, I was seen by my neuromuscular physician, Dr. Cecile Fan, a very nice lady, who tried to explain to me why I was here. And she examined me and she said to me, "I'm going to send 4 vials of blood to a special laboratory in St. Louis, Missouri, Washington University." She said it would take a few weeks for results to come back. In the interim, I was continued on this thing called plasmapheresis, which I was supposed to get in Kelowna. Plasmapheresis is often done to remove extra antibodies, abnormal proteins, or other harmful substances from the blood. But to no avail, the plasmapheresis did not work. I was examined by many other doctors, had EMG studies. I had a book on my bedside. Everyone who had saw me had to sign in and basically say their line of work. In fact, when I left the Glen Rose Hospital, after I got out of the hospital, I had over 700 names. I was seen by a lot of people. During my ICU stay, there was this therapist named Priscilla who came to my bedside to stretch my legs and arms and massage them. I also had another physiotherapist know to do other therapies. This was my happy place, my happy time. I was feeling a lot better. Weeks have passed and my lab results had come back. I had 2 of the 4 vials that were sent to the USA that were positive for these proteins called neurofacins. I had neurofacin 155 and neurofacin 140. So according to this study, I was the 17th documented case. This disease is called seropositive CIDP nodopathy. It's an inflammatory autoimmune disorder that attacked the nodes of Ramsay, the junctions between my nerves, making transmission of impulse absent. And as you can see on this diagram, this is the nerve. These are the nodes, the nerve, the nodes. The antibodies, my own body went rogue on me and attacked these. So the impulse couldn't go from one nerve to the other. This is very simple. It's more complicated than that. Anyways, from previous studies, there was some documentation of treatment modalities. I was to get a drug called rituximab. corticosteroids, and IVIG. There was some difficulty initially getting the rituximab. It wasn't indicated for my rare neuromuscular disease. My wife, Dr. Fan, and a few others had to convince AHS that this drug was indicated for this new disease. I was started on IV corticosteroids and IVIG. I have to say, if it wasn't for my wife, my staunchest advocate, I don't know if I would be alive today or recovered the way I did. Once I approved, I received 2 infusions of rituximab in early November. So rituximab is a biological monoclonal antibody whose purpose is to wipe out in my body these things called B cells, basically my immune system. We had to remove the antibodies in my body, which were destroying my nodes of Ranvier and making me paralyzed. I also had corticosteroids, which was used to decrease the inflammatory process. Actually, most disease entities have an inflammatory process. The IVIG is basically plasma from donated blood. When you donate blood, you have red blood cells and plasma. And they take the plasma from 1,000 patients and they inject it into my body. And that's basically there to give me some immunity and to modulate the autoimmune process at my nodes. I was initially getting 5-day treatments of IVIG, and then now I only get a 2-day treatment once a month. I wanted to add, during this entire time, I missed my 60th birthday. My wife had a dinner party planned, but it never happened. So at that time, I was technically still 59. Anyways, a couple of weeks later, in General Systems ICU, I was transferred to the Neuro ICU in the first week of October. Care in the Neuro ICU was much more specialized. I had a care plan that we stuck to religiously. I was very anxious in ICU. As a physician who was now the patient, I know what happens in ICU and I understand the lingo. The respiratory therapist would always tell me my breathing modalities. However, despite all the comforting, and I developed an anxiety disorder. For the first time in my life, I had anxiety and I've never taken Ativan. And this is the first time I've ever taken Ativan. You know, ICU is necessary for acute diseases. And it's also taxing on the human body. I lost 85 pounds in less than 2 months. I was at my teenager Adonis stage. An amazing quick weight loss program. Yay. Anyways, my body was stressed so much at one time that I developed an arrhythmia called atrial fibrillation. I remember when my respiratory tube came detached from my body and my heart got stressed and I passed out. The ICU team was called and revived me and cardioverted me to a normal sinus heart rhythm. The next day when I woke up, I felt pain in my chest. I felt pain in my chest. What does that mean? That means I had sensation. Now, why did I have that pain in the chest? Was it from the heart? It was from when they had shocked me to convert my abnormal rhythm to a normal rhythm. But guess what? I had sensation. As you can see, this is my daily routine. And that was exciting to me because I had sensation. Now on the graphic here, you can see this was my daily routine. I had a nurse dedicated to myself for every 12-hour shift. I had a feeding through my feeding tube, medications and pain control through my feeding tube and through my IV, a daily sponge wash and face wash. I was turned every couple of hours to prevent bed sores. I was seen by many doctors and other healthcare people. I had this thing called cough assist, which respiratory techs would come in and basically inflate my lung and then suck out all the secretions that I had. I also had a tracheostomy care. I had physio. I was taken for trips to the healing garden. And I actually had one special trip outside. The intensivist said, what would you like to do today? And I said, I love to breathe fresh air. And they took me outside to the front of the university hospital. That was an amazing moment. So anyways, this is how I looked in ICU. You know, I never wore a gown. I'll tell you why. I was essentially naked with a loincloth over my private parts. I was always warm. I needed ice packs on my forehead, armpits, and groins to keep me cool. Here's a cartoon here showing that there really is no privacy in ICU, but you know what? That all goes out the door. I did wear a gown when I left the unit for tests and visits to the secret garden or the healing garden. It was late October that I started to move my fingers and my arms. I had movement. I didn't have much power. But my disease process, when you think about it, started in my lower limbs and then my upper body. But here, the reverse happened. It was starting in my upper body, and then it was going to, go down to my lower limbs. I had sensation in my mid-body. My diaphragm, which provides 84% of your breathing, was recovering. The respiratory techs had put me on a weaning protocol from my breathing tube. Oops. From my breathing tube. The physiotherapist had put me on a tilt table to give me the sensation of gravity and start the process of training my core muscles. There were times that I could do the shimmy dance on the bed. I made it a requirement that anyone taking care of me had to do a 10-second shimmy dance. It was fun. It brought levity to the situation and confidence for me. My psychologist would come in and we would have half-an-hour sessions and we'd talk about my anxiety levels. And she was amazing. My anxiety levels started to drop. She told me to concentrate on the daily activities. My breathing was getting better. I was placed on a T-piece and breathing room air and using my diaphragm to exert breathing pressure. So it was early November that I was taken off the respirator, and in less than 5 seconds, the tracheotomy tube was removed. Yay, I could talk, and boy, did I have a lot to say. So in the first week of November, I was transferred to the neuro ward. There I had one nurse that took care of 5 patients. I had no breathing tube, no feeding tube, no urinary catheter. And what I did there is I actually established an official care plan with the nursing staff. This is something that makes for a better experience in the hospital. I had my first official bath in a jacuzzi type tub. It was heavenly. It was fun too. I was told to hold on to one of these handheld showers when I was in the tub. Unfortunately, I didn't have much power. It fell out of my hand and it sprayed the nurse, who was completely soaked. It was really funny. We all laughed. And, these are just some of the moments I'm trying to explain to you what that experience. So she had to go down to the surgical suite to get some scrubs since her regular clothes were soaked. Of course, they've never let this down. Every time I saw her, she used to say, "Remember you sprayed me?" And I'd laugh. Now, at this time, I had some upper body movement and strength. I could breathe on my own. I had some minimal leg movement. Every second day, I was seen by OT and physio. They had me try to sit over the edge of the bed. However, when they sat me for the first time, I would fall over, just like a blob of jelly. But every time, every 10 seconds, every day, 10 seconds, I would increase that sitting over the edge of the bed, and then 20 seconds and 30 seconds. There was an OT there at the University Hospital named by Sarita. And every time I got better and better, she would say, "And that is you. And that is you." Those are really positive things to hear. And I said to her, you know what? That would make for a great title for a book I'd like to write. And that is you. So the photo that you see here is having me on a special, so these are 2 therapists here, and they have me actually sitting to stand. It's a type of device with weights. I couldn't really get up on my own. I had to have some weights to actually push me up, but it was just to get me to move from sit to stand. And I felt really cool. I thought, yay, I can finally stand. As you understand, I was paralyzed, right? I'm still paralyzed at the time, but I could finally stand. So I would be lifted to, a wheelchair. I'd go to this gym that you see there on the thing, and I would do cable exercises, and I would do hand exercises. And again, this was my happy place. I was also seen by a physiatrist, rehab doctor by the name of Dr. Sanchez from the Glen Rose Hospital, who came over to examine me and prepare me for my eventual transfer to the Glen Rose Hospital. And this happened on December the 15th of 2021. This was the last in-hospital part of my journey. I arrived there December 15th. I was seen by the rehab doctors. The resident did a thorough physical exam. And part of that exam, he revealed I didn't have the anal wink. And you guys are probably all laughing. What's that? Well, this made me have a disease or an entity called lower motor neuron bowel routine. I didn't have any feeling on the part of my anus. So what do they do? What do they do in the Glen Rose Hospital? Well, you know what? The nurses are there. So I'd have my bowel movement, and then they would come in and they would stick a finger and remove the rest of the stool. And I felt so embarrassed about it. And she said, this is part of what we do. This is to help you along. But that's the type of experiences I had. And they were all very professional about it. And they didn't make me feel shamed at all. Over time, my bowel sphincter started to work, and I didn't need that procedure anymore. I'm going, yay, hallelujah. I didn't want that to continue. I was followed by an internal medicine physician for basic medical needs and a physiatrist for my rehabilitation needs. Then there was a therapy team that did some therapies. Unfortunately, a lot didn't happen around Christmas time. At that time, my daughter had returned from Dublin. My daughter is studying medical, is at medical school at Trinity College in Dublin, and she came home for the Christmas holidays. I was so happy to see her, getting some other positive things to see. She even practiced doing a neuro exam on me, and she did quite well. I also had my first bison burger on January the 1st, 2022, and my first haircut since August 2021. On January the 2nd, the therapy team was back at it, and we are on a busy schedule. Now remember, I was still paralyzed. I had physiotherapy. I went to a leg clinic. I went to an occupational therapy clinic. I went to a hand clinic. I learned how to transfer a bed to a wheelchair with a board, without a board. I learned how to use a wheelchair properly. I learned how to sit to stand. I learned how to walk. I learned how to climb stairs. I made birdhouses. I painted, and I did aquasize, and then so on and so on. I even got to try this in-hospital apartment that they have at the Glen Rose to see how I could live in a nice apartment by myself. And I did. I survived quite well. I was seen there once a week by my psychologist, my psychiatrist, and sexual health experts, and social work and others. It was a very good team. I had a lot of great experiences there. After all that, and after a rapid improvement, I walked out of the Glen Rose Hospital to my home with a four-wheel walker on February the 20th of this year. Hooray, I finally made it. Now, I just wanted to show you, this is the birdhouse that I made for my daughter. As you can understand, I had to use my hands. That's part of the occupational therapy, to screw things in, to paint fine lines. I even made these little, as you can see on here, I made these little glass windows. And I even put on these fake solar panels. They don't work, but this is the kind of therapy that happened to me. You know what? Although it was great for OT, it was also great for my mental health. And it was a great place to talk. This is part of the therapies. So I'm back home. This is a picture of me actually, just outside my home. And hooray, I was there. I lived on the main floor of my house. I had a bed set up in the dining room. I made some meals. I did not require home care. I had sponge baths in my mudroom because I could not climb the stairs, and I could not have a shower, but I had them there. I walked around with my four-wheel walker. I did not use the wheelchair that you see here on the graphic, but that was there just in case I needed it. I was able to do some basic housework even too. I could even use the vacuum. I did hire a private physiotherapist to provide some therapies until I got called from the Glen Rose to do my outpatient physio and my OT and rec therapy. Eventually, I progressed to walking poles. I made it outside, and I started to enjoy my life. Here you can see I started my outpatient therapies. I'm in a special place called the Courage in Motion Center at the Glen Rose Rehab Hospital. It's a home for the state-of-the-art computer-assisted rehab environment called Karen. It's the first of its kind in Western Canada. It was actually acquired through the partnership with the Canadian Department of National Defence and the Glen Rose Hospital Foundation. It was meant for the soldiers that were returning from Afghanistan. Of course, that's not happening anymore. It consists of this thing called a robotic platform, as you can see here, a treadmill. These are 2 treadmills with force plates, a motion capture system, and a virtual reality screen with surround sound. And so I was put into these different scenarios, and I'd be walking along, and all of a sudden, or if I was on the Edmonton Transit bus, and the bus driver is a little bit drunk, and he would swerve, and of course, everything would swerve, and was trying to test my balance. And I did very well. I had a harness there just in case I didn't fall over. But it was one of those neat things that was provided to me, and it was actually good therapy for me. Again, on the left. On the right, you'll see that I even did some driving simulation. In fact, I was actually driving a BMW there. You could get different kinds of driving feelings. And of course, the software scenario was that things would come out of the woods or across the street, and you had to stop suddenly. So luckily, I did very well. I didn't kill anybody virtually. In terms of my therapy, I had a great physiotherapist named Tammin. And, you know, he had me even going to the outdoor playground, the sort of the kiddie side of the Glen Rose Hospital. I would walk up the stairs and slide down this, and it was all to get that feeling and sensation. Even had me do some soccer skills, and that was great too. I really, really, really enjoyed that. And this was the day I rode the bike. He said to me, "I'm going to get you to ride a bike." And I said, "Are you blitzing crazy?" I said, "I'm going to have a spinal cord injury." Anyways, here's a little quick video on the right. It was amazing. It was just, you know, like I said, if you've rode a bike ride, it's you know, you remember it, right? I also had some great recreational therapists. I've got Shelly on the left here, to your left, Jennifer, the lifeguard, Riley, and Pam. And they were all part of my recreational therapy, from swimming to crafts to painting, all kinds of things. I really enjoyed that. They have actually quite a nice pool at the Glen Rose Hospital. Then it was back to life. I had the opportunity to go back to a lot of my things with the Faculty of Medicine. This is the Faculty of Medicine Alumni Advisory Council. And this was the time I got to see all my friends. In fact, the Dean of Medicine's at the very back there. And I gave a lecture, but this time I didn't give a lecture on medicine. I gave a lecture on something non-medical about net zero buildings. And it was a breath of fresh air. And you know what? And I stood for an hour giving this. And so it showed that I had the resilience to do this. No, it's Daisy. Then, oops, I had the opportunity to go to the Banff Springs Hotel with my wife. And I said, I got to try to climb the 125 stairs that there are from the top. And I did do it with the poles. I mean, it took me about half an hour, but I did it, right? And it was really good for my exercise. And I did it. You know, I'm always striving for the most. And you know, I know Dr. Fan would say, you know, you got to take care of yourself first and make sure you don't overdo it and all that kind of stuff. Yeah, but you know me, and there are a lot of things that happened to me that I haven't told her yet. But anyways, I did do it. And then we also went to Johnson Canyon. And of course, this was May. There was still some snow on the ground. My wife and I did a 3.2 mile hike. It was very, very beautiful, and we made it. Anyways, I was there. And then at the end of May, I did this thing called the 3K Walk. It's the track community run. It's an organization that I had started with the community. And it was sponsored by Live Active. It was another committee that I sat on with the University of Alberta, City of Edmonton, and the province. And it's just to get you to move. And I did the 3K walk with my poles, and it was great. So I'm striving a lot to try to get out there and to walk, because my goal was I wanted to walk. I wanted to walk. And then in Jasper, again, we went out, and I'm here with my daughter and wife, and did a lot of walking, did a lot of stairs, and climbed some trails and hiked. And again, that was all great. Now, this is me at once a month. So I'm off prednisone. I don't have rituximab anymore. And the only real treatment I'm getting is this IVIG, this plasma. And I get it every 2 days, every month. In fact, I had my last infusion today. I call it my spa day because I go there for 2 days in a row, spend 3 hours. I get some drugs, I sleep, and I'm sitting in a chair, and I get my juice and my cookies, and I'm fine. I've been doing a lot of gardening this summer or this spring. This is my house, and this is how it looked. Not too bad, eh? And then I had a reunion with the neuro ICU. I went back and surprised them. We all cried because you know what? They were amazing. I'm sorry, but you know what? They were amazing. And here I was walking. They said, we've never had a patient come back after they've been sick in our ICU. It was great to see how I did. And that's what I did. And again, here's Priscilla on the right. She was my first physiotherapist who came to me, started massaging my legs. That was my happy place. Now, I told you I'd like to write a book. I've already started. It's called And That Is You. And that was because of that day. So it probably won't come out for a couple of years. I've got to start doing more. And there's one thing here. I received last week the Queen Elizabeth II Platinum Jubilee Medal for all the things I've done for my community and for the province of Alberta. This was really nice to get. Just said that, you know what, I really want to continue with life and I want to do all the things I want to do. And I went back to Orange Theory Fitness. Basically, it's high intensity interval training. Now, I had a bit of a setback in September. I got COVID. I was short of breath. I had some problems with my lungs. I went and saw Dr. Fan. And however, I recovered very well. And when I went back to Orange Theory, it was a good workout. It actually made my lungs work, my diaphragm work, and it was a great thing to do. And on the right side here is me. Sorry, there's time here. Just a second here. I'm almost done. Here I'm doing weight. This I was pushing actually 500 pounds. This was the other day. Okay. Now this is a mountain. Go back. This is called Mount Fisher in BC. I climbed this in 1979. And I'm hoping in a couple of years I can climb it again. It doesn't require much ropes. There's just some small slippery areas, but you can basically walk up to the top. Now here's some takeaway points. First of all I want to say is we need to establish an adult patient family advocacy program independent from the healthcare system. What I mean by that is I was lucky. I had a special advocate in my life, my wife, who's a medical doctor. She could advocate for me. Unfortunately, there's a lot of regular people who can't advocate very well for their loved one. They don't understand the lingo. They sort of have this kind of advocacy program with the Stollery Children's Center. And it's very independent. And I think that's something that we need to do for the adult portion. Also, another takeaway, as a patient, make yourself a care plan with your doctor, nurse to say, this is what I want to see. When I was in the neuro ICU ward, I said, look, I want that nurse when they start at 7 to come and say hello to me. Just say their name and say, look, do I need to see you now or can I go and see my other patients? But just come and say hello. Establish that. And then the rest of the other stuff. And then another thing is, after I'd finished all my outpatient therapies, what do you do next? So we need to establish a post-outpatient therapy exercise and program as well too. I think there needs to be follow-up because if I don't move my muscles, they atrophy. And if there's no muscle there, what's the nerve going to do, right? It's going to die too, right? So we need it to happen. I have to work out all my life, but let's see if we can establish something. And we need to do more research and we need to fundraise. We need to fundraise and provide money for this institute. And we need to fundraise for research and all kinds of things. So let's do that. And enjoy your life every second of the day and live it with gusto. And enjoy time with the family. So I want to tell you, I can walk, I can talk, I can ride a bike, I can jog on a treadmill, I can climb upstairs and downstairs, but I hold on for safety reasons. I can drive a bike, I should say, drive a vehicle. I can type quickly on a keyboard. I can cook, I can eat, I can breathe, I can feel. I can push heavy weights, I can listen, and I can cry. Thank you very much.
Thank you very much, Robert, for an outstanding presentation and an incredible story of inspiration for all of us. Very much appreciated.
Thanks.
We're running slightly behind time.
I'm sorry about that.
But we needed to hear this full story, and our timing is a bit flexible tonight too. So our Zoom isn't going to shut off and cut everybody off at 8. So we'll see how things go here. I just wanted to introduce Dr. Cecile Fan here, who's my colleague, neuromuscular neurologist, specialized in muscle disorders, neurogenetics, neuromuscular disorders. She's an associate clinical professor at the Faculty of Medicine and Dentistry here. Cecile was heavily involved with Robert's condition, his diagnosis, sorting out the antibody testing, which is fairly novel. And Cecile, I wondered if you wanted to just make a couple of comments from your perspective.
Thank you so much, Jeff, for the introduction. Thank you, Robert, for an incredibly inspirational presentation. And I must say that even though I was there for every step of it, I still felt like I've learned tremendously from it as a physician, to understand what you and other patients have gone through. And because I think that is a very important aspect of care, when we understand what patients are going through in the physical as well as emotional, spiritual, and emotional realm. I don't have much to add. You've gone through the major points. What I would like to drive home is, yes, we can have the more common Guillain-Barré syndrome to the really rare condition that you had. But in order for us to get from the point of correct diagnosis, proper support and treatment for you in hospital, proper rehabilitation services available to you outside of the hospital, takes hundreds and thousands of people working on the scene as well as behind the scene. And funding and support is so important for the patients, as well as the medical system providing this care. Anywhere from training our residents and students to recognize this condition and other healthcare providers to recognize condition, to providing appropriate rehabilitation facility for our patients. You're very lucky because you live in Edmonton and the facilities right here. We have hundreds of patients who do not live in Edmonton and who do not have access to the rehabilitation, which is so critical and so crucial. The other aspect, psychological support, is the mental health support system is inadequate to begin with, let alone for patients who are acutely ill and who are recovering. So there are so many areas that we need to work on. One patient's journey is an inspiration in and of itself, but what we would like to do is to create a system where equal opportunity is available to every patient, regardless of their background, of their connections, of their power, of their, economic background. And I think that is, as a society, we owe that to our patients, like you said, to provide that equal access to everyone, so everyone will get the same chance at being correctly diagnosed, correctly treated, correctly rehabilitated, and correctly re-entered into society. But again, thank you so much for letting me be a part of your journey, and I'm honored.
Thank you very much, Cecile. And I should also point out that Cecile's been on the forefront of understanding these new versions of, we still call them Guillain-Barré syndrome, but new versions of them with new antibodies that are attacking targets that we don't even know about. So it takes specialized, well-trained, dedicated people like Cecile just sort of where we're going with some of these new disorders. I'd like to next call on my colleague, Dr. Christine Weber. Christine is an associate professor in the Division of Anatomy at U of A. She has a research laboratory that looks at nerves and new ways to regenerate them and to understand them. I've known Dr. Weber for a number of years now. She's a very creative, intense neuroscientist who's doing some fantastic work, and she's going to give you a taste of what she's been working on more recently on the research side. Thanks, Kristen.
Thank you very much. Can you hear me? Good. All right. Well, that's just not fair, Robert. This is going to be like following the Beatles. That was just an incredible talk that you gave, and thank you very much. That was just wonderful. What I'm going to be talking to you guys about today is not Guillain-Barré's, which is an immune response that will cause nerve damage, as Robert so nicely showed you. What I'll be talking about is how to get nerves to grow once they've been injured. And I'm not a clinician, I'm a basic scientist, so I'm going to show you what we're doing in the lab. So peripheral nerve injury is quite common, and it's about 3% of trauma victims in North America have a peripheral nerve injury. The nerve repair surgeries, although are incredible these days, are not always successful, especially if the nerve has a long way to regenerate. Nerves unfortunately grow at only about 1 millimeter a day. So if you think about if you have a nerve injury up high and they need to regenerate all the way down to your limbs, and especially your lower limbs, it may take over a year to get for that nerve to be able to grow to get to its end organ, which would be the muscle or the skin. And after a certain amount of time, the muscle will atrophy or become permanently damaged. So even, let's say, after 18 months or 2 years, if that nerve finally makes its way down to that muscle target or that skin target, it may be too late to form a functional connection. So in the lab, we're trying to find ways to make nerves grow faster. We have a experimental procedure called conditioning electrical stimulation. And what we do in the lab is we take an apparatus that looks like this, and we can electrically stimulate the nerve. And it's at a low hertz of only about 20 hertz for an hour, causes the muscle to twitch. And we wait a week and we can watch to see how nerves grow. And we've noticed that these nerves that have been electrically stimulated can grow faster. In this little cartoon, I'm just going to show you just a typical neuron. This is a typical sensory neuron. It doesn't matter though. You have a neuronal cell body and you see this long rod here. That's the axon. And so the axon will go all the way down the length of your arms or your legs to the appropriate muscle or to the appropriate skin. And what you can see here is myelin. Lots of the nerve fibers or axons are myelinated. Now, when we put an electrical wire around a nerve and electrically stimulate it, we have shown that it can promote nerves to grow faster. And importantly, it does not injure the nerve. So that electrical impulse will cause signals to come back along the axon and go up to the neuronal cell body. And that's where all the DNA is. And what it can do is this signal can promote the neuronal cell bodies to make regeneration genes. So genes that are specifically increased to promote nerves to grow faster. These regeneration genes, what they do is actually there's a whole intracellular event. There's a whole bunch of events that are going on, and we're still learning about them inside the nerve cell. But essentially what we do know is that they make these end products called actin and tubulin, which are basically the scaffolds of the axon. So if you imagine it, just if you want to repair a highway, if you, on the day that you want to repair the highway is the day you go shopping and get all the cement and the rebar and whatnot, your progress would be relatively slow on the first couple of days. However, if you went shopping and got all the rebar and all the cement and all the trucks and all the men and women and got ready for the building process on day one, you can get that highway built faster. Well, that's essentially what the electrical stimulation is doing. It's going shopping in the nerve, and it's producing all the scaffolding proteins or molecules that that nerve fiber needs. So it's ready to go, and it can regenerate faster because of it. And we can measure the rate of nerve growth. And in our nerves that are just growing, they only grow at about 1 millimeter a day. And that's the same as it happens in humans. However, if we electrically stimulate that nerve, it can grow 3 to 5-fold faster, which is fantastic. This conditioning electrical stimulation is beneficial for nerve regeneration studies because it's not invasive. It does not cause nerve injury. It doesn't cause a big immune response. And we've shown in the lab that it promotes nerve regeneration and for a faster recovery. Just one example of a paper that we're working on to show some of the beneficial effects of this conditioning electrical stimulation is a method to treat foot drop. So foot drop in humans is a condition in which one of the lower limb nerves, it's called the common peroneal or common fibular nerve, it's got 2 names. If that nerve is injured, then the leg, when you're walking, you can no longer lift up your foot. It's called dorsiflexion. You can no longer lift up your foot. So you kind of trip on your own foot, because in a normal gait cycle, if you think about it, you lift up your leg, you flip your foot up, and then you put your foot down. When you have foot drop, that nerve is no longer plugged into those muscles that allow that the foot to dorsiflex during that gait cycle. So you trip over your own feet. And it's since we're talking about an injury that occurs in the lower limb, I've already told you that if nerves have been injured in the lower limb and you have to grow over a long distance, it can be quite slow and tedious, and the nerve might not get to the muscle to repair that injury. What we have shown, so this is an example of the nerve injury of that common peroneal or common fibular nerve, the one that's responsible for lifting up the foot. And in our studies, we can actually condition the healthy nerve and then as in electrically stimulate it. And then the nerve cell bodies are going shopping and getting all the actin and the tubulin scaffolding that it needs to regenerate. And then on the surgery day that we're trying to repair this foot drop, we can actually take a nerve from this nerve that was stimulated and plug it in to this injured common peroneal nerve. And what we can see, so again, what we're saying is if we electrically stimulate those nerves, the electrical signal goes back to the cell body and allows those nerves to grow faster. And this is what we've seen in the lab. So if what you're looking at here is a nerve that's growing from its site of repair. And you just need to look at the length here. This is the nerve that got electrically stimulated. This is the nerve that did not. And we can look under the microscope and you can actually see these nicely growing nerve fibers. And at the end of the day, we saw that the nerves that were electrically stimulated were able to grow 2 to 3 times as fast. We were able to show functional recovery, so a return of gait, so able to push down during the gait cycle, but most importantly, to dorsiflex and to treat that foot drop. So although we've been able to show this conditioning electrical stimulation as a way to promote nerve regeneration in the lab, we still need clinical studies to prove that this will happen in humans as well. So therefore, we must go from the bench to the bedside. We still have a long way to go, but conditioning electrical stimulation and many other nerve strategies to promote nerve regeneration may one day be possible in humans. Thank you very much. And this is not just done by me. I've got a whole team of people that perform this bench basic science and a lot of collaborators with the clinicians to kind of try to mimic and relay the bench to bedside scenario. So thank you very much for your time.
Terrific, Christine. Thank you very much for sharing the story. And I'm just going to remind the audience, if you have some questions, to put them in the Q&A. We're going to try and carve out some time at the end to have a bit of a panel discussion and address your questions. So in the Q&A box, you can put your questions in. Next, I want to introduce my colleague, Dr. Ming Chen, who's a professor in the Division of Physical Medicine and Rehabilitation at U of A. He's going to talk about new methods of nerve repair, how we get nerves to grow better and faster, and some of the interesting advances. And so as a collaborator with what Christine has just described, Ming is moving some of these ideas into the patient. So Ming, why don't you go ahead?
Great. Well, thank you very much for the introduction. You can hear me okay? Perfect, yes. So I'm just going to put my slides on, but I just want to thank the speakers before me. Rob, the great story that you told about your journey. I think that's very candid and really inspiring, just to show your determination. And Christine for setting up the stage for my talk, which is more clinically oriented, but some of that is certainly based on the scenarios that you have work on in the background in basic science. So I just want to focus on one particular surgical development that really has been quite impactful in terms of getting nerves to grow faster and better. So just to lay the landscape, as Christine mentioned, that peripheral nerve injury is very common, but it really is particularly a disease that impacts a young man, as you can see on this bar diagram on the left, with the black bar for male, especially young male, in the early 20s. And these individuals, until their accident, most of them are very healthy and active, but in an injury that involves the nerves in the arm here, for example, high up in the neck, head and neck area, in the shoulder area, all of a sudden they would lose the ability to use their arm, which is obviously devastating. Now, for the last, up to the last 10, 15 years, for 60 or 70 years in the past, the traditional method for someone like that is to do what is called a nerve graft repair. And what is shown in the figure here to illustrate that is that if the nerve is damaged up around the neck, you will need to get nerves that is functioning. And in most cases, we take them from the leg, and then we would put that in between the segment high up, and then to bridge the gap. Now, there are several problems with this. The first one is that this is a major operation, as you can well imagine, of having to take nerve from the leg as well as open up an area that is packed with other nerves and the spine. But what is more problematic than that, as Christine pointed out, is that even if this procedure is successful, the nerve graft would grow at a speed of 1 millimeter a day. And in order for that to reach distant targets such as the hand, it would take forever. And in many instances, that just doesn't happen. And the repair does not produce any meaningful functional return. So what has been a game changer in the last 15 years or so is illustrated in this figure here, that on the left, in the past, this was the kind of anatomy that was thought to be the case, in that the bundles of nerve that goes on a peripheral nerve, they were thought to have different branches and that they intermingle and becomes quite mixed. So if you were to try to use one of these nerve bundles as a healthy donor, when you cut it, you never really quite know what functions that you're going to, you may be sacrificing. However, with better microsurgical technique and the ability to open up nerves without the wrapping of nerves on the outside without damaging the underlying nerve fibers, it became obvious that nerve fibers actually do not intermingle randomly with other nerve bundles, but rather very early on, when the nerves are formed, leaving the spinal cord, they generally run a pretty strict course to very specific targets. And so if one was able to test to stimulate the individual nerve bundles and recording from the target muscles, you can basically figure out quite easily where these nerves are destined. So with that, then you can selectively pick out nerve bundles that you might potentially be able to use as donors. And I will illustrate that in a subsequent slides, but just to also show you that in real life, in the operating room, when the surgeons open up nerves, you can see that the nerve bundles inside the wrapper is that they run really just, quite clearly along the length of the nerve, and individual nerve bundles, they do not intermix. So how can we capitalize on this new knowledge to use the nerves as a donor for damaged nerves? So in this particular situation, I would just kind of illustrate that principle with the nerve transfer. So what it is a patient here who had an injury to the nerve up here called brachial plexus, and it has particularly affected the axillary nerve, and that nerve controls the deltoid. So basically, that is a movement that they would lose or not be able to raise the arm because the deltoid is no longer working. So what the surgeons are able to do is that they will go to an adjacent nerve called the radial nerve here, and that controls a good number of muscles, but in particular, the muscles down here in the upper arm, the triceps. And by opening up the wrapper, they're able to select one particular branch that controls one part of the triceps muscle, and they're able to use that as a donor. Now, this branch is considered as dispensable, and the reason is because triceps have 3 muscle bellies, and they basically all do the same thing. And by sacrificing this branch, the elbow flexion functionally is still preserved. So in this diagram then is that they take that branch from the radial nerve, integrated in green as a donor, and hook it up to the axillary nerve just as it enters the deltoid muscle here. So this is a patient a young man, very typical of what we see in the clinic, who had a nerve injury on the left side. And I will show you a video of what his functional deficit is, but you can see that the deltoid muscle here is quite wasted compared to the other side. So I just played the video here. So as you can see, he achieved a really quite remarkable return of function. Indeed, he was very active. He went back to the gym and actually took up boxing, as a hobby. So that's just to illustrate the level of function that he was able to gain after the nerve transfer. So another example is to look at the one that Dr. Weber alluded to in her basic study. But in patients who had nerve injury, the common peroneal nerve and the nerve that controls the muscles to the front of the calf responsible for lifting up the foot is the one that is most commonly injured. So in the human, we have a parallel procedure to borrow from this nerve here that is further back in the calf called the tibial nerve. And then we would take a branch of that to part of the gastrocnemius muscle and using it as a donor, coapting that to the injured peroneal nerve, very close to the entry point into the muscle that lifts the foot up. So again, it's just to show you an example of an earlier patients who had the nerve injury, but the nerve repair without the transfer, and looking at the functional deficit. So as you can see, the foot drop is very obvious, and he has to walk carefully. We stop okay. So now we'll move forward to a patient who had the nerve transfer procedure done. And I think it is really difficult to tell which leg was in fact injured, because there's very little difference. And now you can tell, because if you can look at the back of his left calf, that's a surgical scar, so it's the left side. And then another patient who had the nerve transfer doing a different activity, and that is running. And perhaps the most challenging is going up the stairs if someone has a foot drop, and she did very well. So I would just move to other potential utility of this procedure, but to patients with other nerve conditions. And in this one is on a patient with a high spinal cord injury in the neck. And as you can see that his hands are not functional. He's sitting in a manual wheelchair, and someone needs to help him to get around. So using a similar idea as a nerve with peripheral, as patients with peripheral nerve injury, but in this case, the problem is that the spinal cord has been injured. So in order for him to regain any hand function, what is needed then is that to look at the nerves that are in the spinal cord segments above the zone of injury to this muscle. And again, they are muscles that are considered as dispensable because there are other similar muscles that would do the same movement. And then that would be cut and transfer to a muscle that is controlled by the spinal cord below the zone of injury. And the idea is to bypass the zone of injury to make these muscles more lower down to work, in this case, the hand. So this is one particular procedure for that. And you can see this in this enlarged figure is to borrow a branch of this nerve here, the musculocutaneous nerve. And essentially what this nerve does ordinarily is to bend the elbow. But because the biceps is still intact, this branch can be sacrificed, and then it is put into the median nerve, which is to close the grip and bend the fingers. As you can see in this example, a patient who had the procedure done, but the spinal cord injury was in fact 12 years before that. But in this case, the surgery still worked, and you can see on the right side here that he is able to open the grip and also close the grip. Now, functionally, I think it kind of goes well beyond just the hand itself, because if a patient is able to regain control of the hand function, then the person would be able to use a power wheelchair using the joystick, as opposed to be in a manual wheelchair relying on others. And also with recovered hand function and elbow function, the person is now able to use crutches to support. And then with new development such as exoskeleton here that would support the person's weight, that is motorized, then the person could actually walk with that. So I think it's a procedure that is useful to bear in mind, because combined with other technology that might allow the patient to recover quite a bit of independence. What about yet another population, people who had amputations? So in this case is to illustrate that someone who's upper arm amputation with the elbow and forearm missing. The thing to focus on is that there are nerves above the site of amputation that are there and that are still viable. So in this case, that's a muscle to the biceps that would control elbow flexion if the arm was there. Now the median ulnar nerves go to the forearm and hand for hand control. They are still there, except they have no target. So the question is, what can one do to take advantage of these nerves that are still functioning? So what Dr. Kaikin and Dr. Dominion discovered quite a number of years ago as a proof of principle is that they were able to transfer those viable nerves, and they put the ulnar nerve in part of the biceps here, and they put the biceps nerve, a part of the pec muscle, the median and ulnar nerves in the lower part. And what they were able to do is to take advantage of this viable nerve growing into functional muscles that would produce electrical signals, nerve signals. And by doing so, they have electrodes that are placed on the pec muscle to pick up those control signals from the individual nerves for bending the elbow and also closing the hand and so on. So this is an example of a patient who had that procedure done, and this is to show what he was able to do with the prosthesis. So he's using that to control the fingers. And then he will go on to do some functional tasks with this. Fine motor control. So I think this is really amazingly intuitive in how fluid he was able to control that. Now, I'd like to move on to a couple of other scenarios where nerve transfers can also be very useful, but as opposed to the previous examples where people have lost function, in this particular scenario, is that with nerve pain after following amputation, what it is that after traumatic amputation, muscles were damaged and the nerves are damaged. So eventually, quite often, the damaged nerve would grow into a ball called a neuroma. As you can see, these fibers that they don't go anywhere. And they become exquisitely sensitive. So when they're irritated, such as when a patient is trying to walk with a prosthesis and the socket impacts on the nerve end, it is extremely painful with bolt lightning. That's often what is described. So one procedure that can be done and has been done is to transect and take out the neuroma and put the nerve end into a muscle in the stump. And that is to give the nerve somewhere to go, something to do, so the hypersensitivity can be eliminated through this procedure. And then lastly is to look at another scenario of patients with stroke, for example, with spasticity. And this is a common pattern of a spastic arm that is tightly flexed and the fingers tightly curled to the extent that, apart from not being functional, is that it can be painful. So the idea then is that by using similar technique as a nerve transfer to identify small branches of nerves to specific muscles, in this case, a muscle that controls wrist and finger flexion, is to cut that. And by doing so, this muscle is no longer active, and therefore the patient could now open the hand. You can see in this real example that apart from eliminating the pain, would also give the patient a degree of function back in the hand. So with that, I just like to summarize 4 major takeaways. And first one is the nerve transfer technique that I described could markedly improve functions in patients with peripheral nerve injury. But more than that, I illustrated the principle on other patient populations as well, in spinal cord patients and amputations, just as examples, and then neuropathic pain and spasticity. And then lastly, I think the important thing in terms of looking forward is that instead of staying alone, to move forward by combining new surgical innovation with advances in basic science discovery, such as that described by Dr. Weber, could potentially bring improvement that is much better than what we're able to do at this point. So with that, I just like to acknowledge all my colleagues in the Central Northern Alberta Nerve Injury Clinic that comprise of surgeons from different disciplines, physical medicine, the rehab, as well as basic scientists and allied health. So thank you very much. That's the end of my presentation.
Thank you very much, Ming. Very nice presentation, some very exciting developments there. Plenty to talk about. We've got lots of good questions in the Q&A. I hope we can get to at least a few of them. We're looking forward to that. I have something really special for you now. Another very inspirational story delivered by someone who I met a couple of years ago at the Neuroscience Fun Run. Her name is Holly Francis. Holly is an author and a GBS survivor and advocate. As a 26-year-old, she had just given birth to her first child and was diagnosed with a severe and prolonged form of Guillain-Barré syndrome. I can tell you that she has a book written. It's almost out, another month or so. I've had a chance to preview it. It's an incredible story as well. And I think you'll like to hear from Holly. Thanks, Holly.
Thank you so much for having me part of this. Robert, I can relate so much to what you went through, and I'm just so happy to see you here sharing your journey with us. I know that being firsthand what I've gone through it as well. So I know how much hard work you put into it. Ming and Christine, thank you for sharing those presentations. Before this, no, I had no interest in the body, but I'm just fascinated in the human body and what we can recover from, and all the things that the research that we're doing. So thank you for your presentations. So I'm just going to share my screen here. All right, so from Guillain-Barré syndrome to happily ever after. So my story is a little bit different in that I'm not a doctor and I had never heard of GBS before. So this happened almost 12 years ago, and I would have been 26 years old. I was completely healthy. I had just given birth to my daughter. So at the time I was at home and I was adjusting to life as a new mom. I was, like I said, 26. I was happy, healthy, and I just had my whole future ahead of me. And I was so excited to make all these memories with my daughter. I had all these plans. We were going to go for walks. We were going to go visit our friends. And I was recovering from a C-section, so we didn't do very much. We were sitting at home waiting until we could do all these fun things. And all of a sudden it started with a tingle in my fingertip. And I remember at the time feeling my fingertip and thinking, it's odd, did I burn myself on something? No, I don't think so. I don't remember anything. So I went about my day. About 2 hours later, I had a very severe pain in the very back of my neck. And it came on very suddenly and severe. And I immediately thought that I must have twisted my neck a strange way. But I just brushed it off and continued about my day. About an hour or so after that, I started to go up the stairs. And just like Robert, I noticed that my legs felt kind of weak and heavy, and it just felt a lot harder to get up the stairs. But I also just figured I was really tired. I was getting used to being a mom, and I was waking up several times a night to breastfeed, and I was thinking that I just needed a good night's sleep. So I just tried to ignore it, but everything just continued. The tingling got worse in my fingertip. The pain got worse in my neck, and the weakness seemed to get worse by the minute. And eventually I'm on Google and I'm Googling what's happening to me. And I find out, oh, you have a pinched nerve. That's what I find. So I think that this must be quite a severe pinched nerve. And I try to ignore it. I take some pain meds. Pain meds do nothing. And I tried to go to sleep that night. I'm laying in bed and I cannot sleep. The pain's getting worse and worse. And I'm in tears and I'm thinking, wow, like I just went through birth and this is almost as bad as that. Like, are pinched nerves really this painful, or did I maybe like break my neck somehow? So eventually I crawled out of bed and I'm on the floor and I'm Googling yoga poses and stretches and all these different things that might help a pinched nerve. Well, this goes on for hours, and eventually my daughter, who was in a bassinet sleeping beside her bed, she wakes up and she needs to nurse. And I stood, and when I stood, my legs completely buckled and gave out on me. Now, I still had strength within me, so I was able to stand back up and lock my knees in place, but I knew that something was wrong. I still thought it was just a pinched nerve. I thought it was a very severe one, and I knew I needed to go to the ER. So I had my then husband at the time, I asked him and said, I need to go to the ER. I need to see a doctor. I need to at least get some pain meds so that I can sleep. So he put me in the car and he put my daughter in the car, and I said, just drop me off. I don't want our newborn in the ER. So I'll just call you in a couple hours and I'll let you know how things go. And I'm sure you can just pick me up in 2 or 3 hours. And I had no idea that that would be the last time that I would actually step outside for almost 5 months. So I go into the ER, and I was very, very fortunate that the doctor that I saw, and fortunate even that my case was progressing so quickly, that the doctor that I saw, he said, yeah, you're losing mobility, and you seem to be in a lot of pain, and I have no idea what's wrong with you, but I'm going to call a neurologist and we're going to see if he can find out. So very fortunate for that doctor who referred me to that neurologist. The neurologist then came down to see me. He had me squeeze his hands. He tested my reflexes. And within about 15 seconds, he said, I think I know what you have. I think you have Guillain-Barré syndrome. And I'm 26, and I'm thinking, what the heck is Guillain-Barré syndrome? I couldn't even pronounce it at the time. And I remember thinking, a syndrome, like, is that a disease? I had never heard those words before. And I just remember my mind racing going, this can't be happening to me. I'm in my 20s. I'm not supposed to get sick in my 20s. I'm not supposed to get diagnosed with a rare disease in my 20s. I'm not supposed to get sick till I'm 70 or 80. And he said, yeah, it's an autoimmune disorder, and it's quite rare. And I've seen one case before. So I was very fortunate that he'd seen that case, which helped him to diagnose me. And he said, you need to be admitted to the hospital, and we just need to see how this progresses. And I remember thinking, I can't be in a hospital. I have a newborn. I got to go home. My husband, he's feeding her with a bottle right now of our one and only bottle of formula that we have, because I've been breastfeeding. And he's like, this is an emergency, a medical emergency, and you need to get your family to come to the hospital. So from that point, my family came to the hospital, and it's kind of a blur at that point because the paralysis spread very quickly. Suddenly I was having weakness in my arms. The tingling was spreading. It was turning into severe pain everywhere, not just in my neck. I'm screaming and crying in so much pain. The nurses are trying to get me to bond with my daughter, so they're putting her on my chest, and we're breastfeeding, and then they're prying her off, going, you're on too many pain medications. You have to stop breastfeeding your daughter. And it was just this nightmare, and I had no idea what to expect. They started me on IVIG. They later did a spinal tap, which confirmed that I did have Guillain-Barré syndrome. And they started me on IVIG. I think I had 3 or 4 of those. And then they quickly decided they were going to switch to plasmapheresis. And I'll be honest, I think it was because it was a brand new machine that they had never tried before. And so they wanted to try it out. And things didn't go very well. Eventually, the paralysis spread and affected my diaphragm. Even though we were doing all these treatments, I just seemed to be getting worse. And they said, we have hope. You're gonna get better, and you're gonna recover from this. But I just continued to get worse. Eventually, the paralysis affected my breathing, and I was rushed to ICU, and I was ventilated. So from that very first tingle in my fingertip, which again at the time I didn't really notice that it was correlated to GBS, but looking back now, I do. So that tingle and the time that I was ventilated was 72 hours. So my case came on very, very suddenly. They then switched to plasmapheresis. A very unfortunate accident happened, and I had very, very tiny veins. And when they were doing the plasmapheresis, which involved putting a catheter into the vein in my thigh, they actually ruptured my artery, and I nearly died. So I had a 6-hour surgery. My family wasn't sure that I was going to survive. The doctors said they weren't sure that I was going to make it, but I did. And then I woke up, and I was in ICU, and I had a breathing tube down my mouth, and I could no longer move anything. I had a little bit of movement here and there in my neck and my head, and a little bit in my fingertips. My entire family was there beside me, and I truly did not believe that I was going to get out of this. And I was so heartbroken, and I was so devastated that I had just given birth, and now all of a sudden my life was completely ruined, and I had no future, and my life was over. And I was so angry for such a long time, because I felt like I was so robbed from the opportunity to be a mother, something that I'd wanted to be since I was a little girl. And so I had no hope at this time. And like Robert, I actually, in those first couple of days, I said, just shut off the machine. Don't make me go through this. And I can't do this. And just let me go. And of course they didn't. The doctors were incredible and convinced my family there's so much hope for her. She's going to get through this one day. She just has to stay positive and just keep going. Well, the paralysis just continued. And I'm going to start here. So this is the very first picture that I have in ICU. This was about day probably 8. And although I'm probably sleeping or quite sedated here, I was fully aware of everything that was going on. I was on a lot of medication. I was in a lot of pain. My heart rate was affected. I was overheating. I can totally relate to what Robert was saying. As you can see, I've got cold cloth on my head and I had them on my thighs because I felt like the room was on fire. The nerve pain was unlike anything I had ever experienced before. And it was from all the inflammation in my nerves. And it felt like I had literally fallen off a building. And then every time somebody touched me, felt like they were taking a sledgehammer to my body. So I was in so much pain and so much suffering. I was heavily medicated. The medication made me very nauseous. I was vomiting up to 20, 30 times a day. And they're trying to put my daughter on my lap and they're trying to keep that bond and that connection, but it almost made it worse for me because it was just reminded me of what I'd lost. So I just continued to get worse. Eventually they took out the breathing tube and they did a tracheotomy because they didn't show any, or I didn't show any signs of improvement. And I communicated by basically my friends would have a piece of paper and they would point to the letters and then I would blink my eyes. And that's how I communicated for a very long time. And I was lost and I was broken. And this is my daughter here on my lap. And it was so hard for me because she's trying to reach out and touch me and I can't do anything back. I can feel her. I could feel everything, but I couldn't move. Now, as time goes on, I ended up being in ICU for nearly 70 days. And for a very long time, there was no signs of improvement. And once again, I couldn't go on any longer. I couldn't handle the day-to-day. I felt like I was living Groundhog Day. Every day was exact same as the last, and so much pain and so much suffering and no signs of improvement. And I asked the doctors and the respiratory therapists, I said, please just let me die. I was very, very fortunate that the hospital that I was at, they'd seen the case of GBS and they had treated a man who had GBS prior than me, and he had recovered. So he came in and he walked into my hospital room. He'd actually been in the exact same ICU room that I was in about 2 years prior. And to see him and to see that he had overcome this was a huge inspiration to me. And so I thought, if he can do this, he was a young dad. I thought, if he can do this, he can get back to his kids, and so can I. So as time went on, I did start to get a little bit stronger. My fingertips started to move. That was the first thing that came back. And then breathing. So I was showing signs that I was going to be able to come off the ventilator. And that was the hardest part. It was like learning how to breathe was like being underwater and about to run out of air. And that's what it felt like all the time. So again, with Robert, I can relate to that anxiety. I had such high anxiety that I'd never experienced in my life. High doses of Ativan, and learning how to breathe on my own. It was so challenging that every time we did it, we started with 15 seconds and then progressed to 30 and then 45. And every time I did it, I was hyperventilating after, crying my heart out, going, I'm never going to be able to do this. And they're telling me it's going to get easier. You're going to get through this. You just have to keep trying. And so I did. And every day it did get a little bit easier. But I remember thinking, I have to last 72 hours off the ventilator before they're going to take out the trach. And it just seemed so impossible to me. But I kept going and I kept trying. And eventually I was able to do it. And I lasted 72 hours. And it was at that point that I really, and I'm going ahead talking here, I wanted to show this picture. This is when I was starting to regain function in my hands. And so we figured out a way to kind of cock my hand up against my daughter's bottle so that I could feed her. And again, this is such an inspiration for me because I wanted to get better for her and I wanted to get back to being a mom and back to living our lives. So after I was able to breathe on my own, that was a huge turning point for me. And from there, I after eating something so impossible to do, I knew that I had to just keep going and I had to keep trying. So I was moved to the neurology ward in the hospital. And from here, my first task was to learn how to sit up in a wheelchair, which was very difficult with the core. For the last 3 months, I'd been recovering from the major surgery, from the artery surgery, and then as well from a C-section. So it was so challenging just to sit up in this wheelchair. I eventually learned how to hold cutlery and how to feed myself, how to brush my hair and teeth. My physiotherapy team came in and we did tons of different exercises every day, right from my bed, and then others in my wheelchair. And I just slowly got a little bit stronger and stronger as the time went on. And it was funny because my daughter, by this point, she would have been four months old. And so she's doing the same thing. She's learning how to grasp things and she's learning how to hold her bottle. And so it was so amazing that we were doing it together. And I remember thinking, you know what, she's doing it for the first time. And if she can do it, I've already learned all this. I've already done this, so I can do this. I've got this. I was eventually moved to the Glenrose Hospital, where Robert was as well. And there I learned how to basically type and write and how to use my motor skills again. I eventually progressed to standing. The first time I stood for 30 seconds at a time. And like breathing, I thought, I'm never going to be able to do this. This is so hard. How am I supposed to walk? But I just took it one step at a time. And eventually I was able to move to a walker. And at that point, because of everything that was going on with my daughter, I mean, I was losing out on so much with her. She was at home and she was smiling and she was going for walks, and I didn't get to do those things. And I wanted so desperately to be at home with her. So my care team actually allowed me to go home quite a bit earlier than probably should have. And they recognized that emotional bond was maybe more important than my physiotherapy at that time. Maybe my physiotherapy would take a little bit longer. And I was okay with that. I just wanted to go home. So I went home after 126 days in the hospital. This is me right outside the Glenrose. And just so excited. And I returned home to my daughter. And I knew that my therapy was all on me. I didn't have physiotherapists. I did a little bit of outpatient therapy, but not for long. And I knew that it was all on me. And I knew that if I wanted to get stronger, if I wanted to get out of using a wheelchair for long distances and out of the walker, that I had to put in a lot of work. So I started doing exercising. And before that, before my 20s, I never really exercised. It just wasn't a part of my lifestyle. And so this was so new to me. And I started exercising on my couch, and I started doing exercises just whenever I could. And I would go for walks with my daughter. I used her stroller because that was actually even more stationary. So it was easier for me to use than the walker. And I tried to walk as long as I could. And eventually I got stronger and stronger and stronger until eventually I was actually in the best shape of my life. Not in all areas. I still had a lot of weakness in my ankles, a lot of weakness in my hands. I still deal, to this day, I still deal with a lot of nerve pain, as well as fatigue and everything. But overall, I really am in the best shape of my life now. So after I recovered and I tried to go back to my life, and it was just mind-blowing what I went through. And people were coming to me asking me what it was like to go through Guillain-Barré syndrome. And they're asking me what it was like to be in ICU, especially all my friends that are in their 20s. And it was impossible to explain that in one conversation. So I actually wrote a book at that time. This would have been 10 years ago. And I quickly wrote a book about what I had gone through. And I shared it with my friends and family. It was really meant for them. And I pieced together all the videos and photos that my mom had taken of me in the hospital. At the time, I didn't like it, but eventually I enjoyed looking back on my journey. And we put it out into a YouTube video, and that video ended up going viral of my recovery. And from there, my life changed completely. Suddenly I was being contacted by people that had GBS 20 years ago, and they'd never met a GBS patient in their life. They didn't even know that there were other people out there that had their disease too. And they were connecting with me, and family members were reaching out to me saying, I can't believe that you've gone through this and you recovered. My family member is in ICU right now, and we didn't believe that they were going to get better. And seeing your story inspired us. And doctors were reaching out to me saying, thank you for spreading awareness and for bringing light to this rare illness that so few people will ever deal with. And I knew at that point that my life was going on this new path, and I had this unique, very unique perspective to share. And so from there, I actually started rewriting my book because there was so much that was going on at the time. And I started to get involved with the GBS Foundation. I found them. I found this whole community of people that had gone through what I did. And everybody's cases were so different, but so similar. And I started getting into running. I ended up meeting Doug at one of the events. I ended up running, and that event I actually talk about in my book because I set a goal and I ended up running the fastest I'd ever ran in my entire life. And so now I am heavily involved with the GBS CIDP Foundation of Canada, and it is truly my passion. And the purpose of the foundation is to basically engage in advocacy, including treatment access at the federal, provincial, and grassroots level to improve the quality of life for individuals, families affected by GBS, CIDP, or variants such as MMN. So the foundation is incredible. I'm so proud to be a part of it. We have so many services available. We do hospital visitation. That was very challenging for me to walk into an ICU room again, but it's something that I actually love to do now because it's to be able to walk in and give that hope. We do peer-to-peer support in person and online support group meetings, educational programs such as conferences, webinars, videos, etc. We provide names of physicians specializing in the conditions. We do newsletters, we do research funding, we do patient advocacy, awareness events, patient stories, and many, many conferences over the years. And it's been incredible just to meet people that have gone through what I did, and then as well get to meet medical professionals who are so fascinated by the disorder, and I'm able to educate them, even though they're the doctors, that I may be able to share my story. We have an incredible medical advisory board on the GBS CIDP Foundation as well. And for anybody that wants to, they can also register with the foundation. So I'll just stop sharing. So yeah, I just wanted to really thank you all for listening to my story. What I've really learned over the years is that GBS is so different and cases are so different. But I think it's so important for doctors to get to know the patient and get to know their own unique journeys, and to really remember that there is life after GBS. I have met so many patients over the years that were told, like me, I was told at one point in my journey that I probably wouldn't walk for 2 years, and I walked in about 6. And I see that happening a lot. And so that's one of my biggest takeaways, is that even the most severe cases of GBS do recover. Not always, but I think there's always that hope, and there's always that potential. And we want our doctors to be able to give that person that hope. So I do have a book coming out, and I'm so thankful for Doug for reading it. And I just want everyone to know that there certainly is life after GBS. Thank you.
Thanks very much, Holly. Another very inspirational presentation. So very, very much appreciated. Thank you for doing this. Well, we're going to wrap up here fairly quickly. We do want to get to some of the questions. I had some slides, but I'm going to really shorten this a little bit as well, so that we don't go too far over time. I'll make some points, and that is, you've heard how prolonged a severe inflammation of the nerves is that causes Guillain-Barré syndrome, neuropathies. These are prolonged, they take chunks of people's lives out. And you've heard the challenges about getting nerves to regenerate. And yes, we have IVIG and we have some anti-inflammatories for some of the inflammatory causes. But in 2022, we do not have any pharmaceutical treatments to encourage nerves to regenerate better. We have some very interesting new strategies that we heard from Christine. We'd like to change that though. We'd like to have more research and we'd like to identify molecules that might shorten these courses. And you've seen these series of events that occur in nerves when they're damaged and then they're trying to regenerate. There's something called the growth cone, which is the very tip of the growing nerve that needs to find its way back to the proper muscles. And you've seen how Dr. Ming Chan tries to reposition the nerves so they can do exactly that. But we need to encourage these growth cones to move. So we need 20 or 30 new molecules, and maybe one or two of those are going to have an impact on regeneration that we can prescribe. And no matter what the duration of it is, these are just a few of them. And I'm biased because there's a number that we've worked on in our lab, and they have funny names like P10 and RB1, but they're molecules that are present in nerves that seem to prevent growth. And in injuries and neuropathies, we want growth to occur. We don't want to prevent growth. There's molecules at the growth cone that we may be able to do something with. The Schwann cells are these partnering cells that surround each nerve and kind of provide the myelin and insulation, but they also support the nerves as well. So I'm just going to show you a couple of pictures of how the research starts. You've got to start somewhere. And so what you can do is put nerve cells in a dish, look at them, and see which molecules make them grow. Here's what getting rid of this roadblock called P10 does. It allows the nerves to start sending these processes all over the place, whether they've been injured or not. This is an interesting video here of a neuron sitting in a dish, right? Here's its process and growth cone. And if you squirt a little bit of the inhibitor of P10 to it, it starts to grow, and all the branches, even far out from where you're spraying the molecule, start to grow and enhance. So this is the very starting point of how we're going to understand regeneration. But it's going to take work from everyone on all levels to understand these things. Here's if you remove P10 and you add insulin at the same time, you can see these remarkable outgrowths of the nerves. And they're a reasonable predictor of what might happen if you could infuse it into a nerve injury. But we're not there yet. We do not have any specific treatments to encourage nerves to grow better. There's one called retinoblastoma. When it's aberrant, it causes tumors in children, but this molecule is present in nerve cells and it's blocking growth. And there's a complex mechanism for that I won't get into. But if you remove RB1 by this technique called siRNA, they begin to sprout and they begin to grow. They're just not static things that are sitting there with processes. They have what we call plasticity and the ability to grow here. And here's another example of knocking down RB1 and seeing improved growth. You remember that picture of the skin I showed you at the very beginning of the evening? These nerve cells, these nerve axons that are present in the skin give us sensation and feeling. Here's what happens if you can treat a nerve injury, in this case, an animal study in a mouse with an RB-siRNA, and you can grow more fibers here into the skin. So this is the kind of how the work progresses. First, you look at the neurons in a dish, then you look at mice to see how you can get the nerves to grow better. You can use machine learning. This is really exciting for us because we've been able to move from the siRNA to perhaps some small drugs that could have the same effect as getting rid of RB1. You see these beautiful arbors of nerves growing out. Why can't we do that yet with the patients? And finally, we do know now that if the nerves disappear, their neighbors can send out branches. And that's a whole nother process of recovery called collateral reinnervation. And we know that the nerves in the skin, for example, are still capable of growth. So all of this slide is to show is a number of pictures of those nerves in the skin, but they're also lighting up with growth molecules in them. And if we can somehow use these growth molecules right in the skin, could we encourage more collateral innervation? And this was a patient with CIDP before and after IVIG, and before and after it as well. And we saw more growth molecules in the skin as this person recovered. So here's my takeaways from this presentation tonight. Nerve disorders are very common. We heard about some really tough, difficult ones. But if you took the whole spectrum of nerve disorders, including diabetes and nerve injuries, they're very, very common. The severe disorders get better, but they require a lot of sacrifice, and it's very prolonged. And those are the stories we heard tonight. The survivors of these events are really heroes, especially when they can tell their stories and let us know what they went through, like Robert and Holly tonight. So we may get new surgical approaches. You heard from Ming. The electrical stimulation shows a lot of promise, very exciting, non-invasive, and new molecular treatments that our own lab is interested in, but more work required. Can you help? Yes. We need advocacy, not only for neuropathy, but for neuroscience in general. The governments, granting agencies, industry, to get involved in this and develop new treatments. Holly nicely mentioned the foundation. The Calgary Neuropathy Association, of which people have connected tonight, has been a wonderful venue and group that I got to know when I used to work in Calgary, for bringing persons together and discussing their individual challenges. Help us to identify better research support. And help us keep the Institute alive. I do have to say, sadly, that with the cuts and where things are going at the universities, this is touch and go. The NMHI lives year by year. We're living on fumes, I like to say. So if you're so inclined, please talk to your MLAs. Step 1, reverse the cuts. Step 2, let's do better. Let's find better treatments. And I'm going to stop there. At this stage, I want to really thank all the speakers and thank the audience. And I'm sorry we didn't get to all of the questions, but I really appreciate your attendance and joining us. And again, a big thanks to our speakers today for participating in this. I will also say on January 26th, we have a tentative NMHI presentation live, not Zoom, live, on Alzheimer's disease for Alzheimer's Awareness Month. And that you can also sign up for our newsletter, The Neuron, for the NMHI. And we could just finish, maybe Ramona, if you want to just post that link, if you're able to, for how to get the community newsletter. And with that, we'll say it's a wrap. Thank you.
Thank you very much.
Thank you.
Thank you for the opportunity.
Absolutely. Thank you.